Ma'am, I'm starting the session, ma'am.
Okay.
Good evening, everyone. I welcome you all at another webinar of ICRI teaching program. I request the organizers to start the session. Over to you, ma'am.
Good evening, everyone, and a very warm welcome to today's ICRI teaching session. The theme for today is breast imaging. Each of us sitting today here knows that breast cancer is the most common malignancy among women globally. It has now surpassed lung cancer as the leading cause of global cancer in the world, surpassing breast cancer. We all here as radiologists and oncoimaging specialists should know the importance of early detection in cases of breast cancer. With keen eyes, we are truly the light to a surgeon's knife. Possibly spotting something new every day, it might give us one more piece into the massive jigsaw puzzle of breast cancer. Throwing light on the same today, we have eminent speakers Dr. Sudhakar Sampangi and Dr. Mukta Mahajan, who will talk us through mammography and MRI techniques. A warm welcome to all dear speakers. We are truly looking forward to learning from you all today. I would like to encourage the participants to use this opportunity to take back knowledge on breast cancer and to freely ask all their queries to our dear speakers by using the chat box. So our first speaker for today is my teacher and my guru, Dr. Sudhakar Sampangi. Sir has extensively worked in the field of breast imaging, and he has played a pivotal role in changing the landscape of breast imaging in India. His achievements, dedication, and commitment is truly inspiring, and I have had the fortune of witnessing it firsthand. Sir currently is a consultant at HCG Bangalore. He is a faculty in South Asia for training in ultrasound elastography and ultrasound guided biopsies, as well as vacuum assisted co-biopsies. Sir has numerous publications and presentations to his honor. We welcome you, sir. I request you to start your presentation, sir.
Thank you, Dr. Nadazda, for introduction. I thank IRIA for IRCI for giving me an opportunity to share my experience. So today I'll be talking more on clinical aspects which we commonly encountered during our clinical practice in reporting mammography system. So here, most of time, the what we face the difficulty is with the techniques in which in how we obtain, and sometimes we end up doing inequality work because of the technical factors. So I'm going to highlight all those technical factors and the difficulties what I face. So I'll be covering with the mammography techniques, the indications, and I'll be guiding you how to report the mammography reporting with the biorecords. And in the end I will show you some interesting cases. So imaging modalities, what we have predominantly is a mammography and ultrasound scan, MRI, and facetal emission mammography, which is not there in India. So today I'll confine myself to mammography. So in the mammography, so we have this has been the basic modality of breast interpretation, and this is the first line of imaging investigation, and this is the only technique to show us showed as to reduce cancer mortality. So here the low energy X-rays are used. As the energies are less than the size of less than the 40 kV, so it is this less than 40 kV. So, and whenever it is a thinner breast, we use a low kV. Whenever it is heavier breast, we may have to use a higher kV. This helps in based on the penetration of it. And we get average dose of around 1.5 to 2 milligram per exposures. So since the mammography is a surface tissue, it is a kind of modified sweat glands, and it's present between the superficial pectoralis major muscle, extend from second rib to sixth rib. So it contains predominantly a parenchyma, which contains a glandular tissue. We got around 15 to 20 the lobes, which contains a cluster of alveoli and the lacteous duct. And there is a skin with the nipple urinary complex, and there is a stroma which contains fibrous tissue as well as a fatty tissue. So here, this is a gross picture which shows the pectoralis major. The breast tissue extends from the pectoralis major up to the skin. We got multiple lobules here, and there are a lot of connecting tissue is a fatty tissue, and between the fatty tissue which anchors fatty tissue as well as a glandular tissue which is anchored by the ligaments of Cooper, which extends from the pectoralis major muscle up to the skin. And when it comes to the glandular component, here in the glandular component, we got a functional unit that's called terminal ductal unit. In the ductal unit, there are multiple acini or the ductules. They are like a bunch of grapes. They organize together, and that will communicate to a terminal duct. So all together, it's called the terminal ductal system. That is the functional system, which is the active system. And whenever we see the ductal tissues, so there are whenever we see the breast tissues, there are changes which happen with the hormones. One is the fibroglandular tissue, which will be abundant in the reproductive age group and also in the lactating women. And as age progresses, the glandular tissue is replaced for the fatty tissues. And so this is an example in which we can see that as the age progresses, this is the glandular tissue, and as the age progresses, we see the retromammary. This is a glandular tissue. Posterior to that glandular tissue is a retromammary tissue. Here it is all replaced by a fat tissue. And there is and other pattern is once it starts, the most common density of the parenchyma is in upper and outer quadrant. So as the age advances, the lower and the inner quadrant, they are the first one, the glandular tissue will start involuting. So whenever you're reporting, make sure that you should also have in your mind the normal involution of the breast parenchyma. So the last tissue to disappear is the upper and outer quadrant of the tissue, and there is one more variant where the retroareolar tissue will appear last. So these are the two variants are there. So these are the slightly bulky breast tissue, whereas a much older age, the breast tissue will further become thinned out. So when we thinned out, we can see streaks of gland. Here you see large blocks of dense tissue. Here we see thin streaks of tissue. So again, when we see these streaks of tissue, again we have to see compare with the outer quadrant as well as the inner quadrant. So generally the inner quadrant, they won't have any glandular tissue with the advanced stage. Only small remnants of tissue will be there in the outer quadrant and upper quadrant. So whenever you are reporting or whenever you are imaging, make sure that you compare the density of upper and outer quadrant before concluding as an asymmetrical density. That I will tell you in detail. And here we normally use two views. One is a medial lateral view and the cranial caudal view, and also supplementary if there is any specific requirements. So most common is a medial lateral view, where we from superior medially to inferior laterally, and we compress the breast parallel to the pectoralis major muscle. We get a compression like this, where we keep the shoulder upwards to the level of shoulder, and we keep the compression along the pectoralis major muscle. So once we give the compression along the pectoralis major, you can see that the part of axillary tail is included. Whereas the tissues which are close to the chest wall, especially in the parasternal area, will be missed out, and also the tissues which are in from mammary fold are also missed out. So to conclude, to see whether we have obtained the adequate exposure or not, so we have to draw a line, the line which should a line which is parallel to the pectoralis major muscle, and a posterior nipple line which straightaway perpendicular to the nipple areolar complex. So this line and this posterior nipple line should intersect at this area. So here it is not intersecting, whereas in the center you can see that it is intersecting. The pectoralis line is much more below it, and this image it also shows it's much higher above. So the disadvantage with this, as you can see, I'm not seeing the posterior component of this glandular tissue, whereas the posterior component is clearly seen, and I can see one more lesion which is deeper to the retromammary zone. So here I'm missing totally, the inframammary zone is totally missed. So this becomes very important when you are not got the adequate exposure of the medial lateral view. Again, in the craniocaudal view, we give a vertical compression, craniocaudal compression we give. Here, as we can see, the axillary part is not involved in this, so you are likely to miss all the masses which are in the axillary tail of breast. So make sure that you ask your technician whether that was there any lesion in the axillary tail before reporting. And here you always include, you see whether you have any retromammary fat seen on the craniocaudal view. Sometimes we can see a pectoral muscle also. So once we see the retromammary fat, that means it is an adequately exposed craniocaudal view. There are some additional supplementary views, that is the exaggerated craniocaudal views, true lateral views. This is used whenever you are trying to localize the lesion, whether they're in the true 12 o'clock position or 6 o'clock position, because generally we give a oblique view where we may not have a slight proper oblique position, and there is a Cleopatra view whenever the lesion is extending into axillary tail, and there is a cleavage view whenever the lesion is closer to the sternum. And we do give a compression. The compression, when we give an adequate compression, there are a lot of advantages. One of them is to reduce the geometric unsharpening and to improve the contrast. So see, whenever we give a compression, the glandular tissue will get scattered. So once we get scattered, the penetration will increase, and also it will increase the contrast between the glandular tissue and the fat tissue. And since it is a little painful procedure and patient cannot stand for a long time, so there may be subtle blurring will be there because it's a long exposure film. So that motion will be diminished by compression. Again, as the breast tissue is thicker, the machine will give more kV, that means a high dose. So to reduce the dose, we give more compression. More the compression, less is the dose. Again, when you give compression, you get a uniformity of the glandular tissues all over. And to assess the accurate assessment of the density in compared to other areas, and to separate the superimposition of the glandular tissue. Again, there are magnification mammogram is used whenever we see a small lesion. So if you want to see zoomed image, you want to see the margins clear, so that time we use a magnification view. So here we increase the film focal distance. Once we increase the film focal distance, as you can see here in a regular mammogram, there is a overlapping of tissue. Once we give a magnification, there will be two close object can be separately seen, and margins will also be well seen. So this is an example. Here I am not seeing a small lesion here, hardly any small faint opacity seen in the retromammary zone. And when we do a magnification view, here we can see a bright architectural distortion, opacity with architectural distortion is seen, definitely it's a Barrett's 5. So here the magnification can go up to 1.5 to 2 times. So this is an example. Here, I'm not seeing much of uh, abnormality here, but as we go closer, here I can see a subtle irregularity. I'm not sure of the disease, but once I give a spot camera, I can see that there is an architecture distortion. So this is an advantage of spot compression. So spot compression, we give a compression on the area of concern. So advantage with this one is it will magnify the view, magnify the image, as well as it will scatter the overlapping tissues. So once the overlapping tissues are taken away, so the lesions will appear obvious. So sometimes we can use a lucent markers whenever we see multiple lesions. There are two lesions here, one lesion here, one lesion here, one lesion here. So one of them may be suspicious. So to know which one is a suspicious on the mammogram, first we do an ultrasound scan. After doing ultrasound scan, we'll put a marker, lucent marker on it, then we'll repeat a mammogram. Or before doing a mammogram on a clinical examination, if there are multiple lesions are there, you want to know we want to know which is a more malignant or less malignant lesion, more concern. So you put a lucent marker on the concern area, then you can do a spot compression. So that will give a better indication. So coming to the indication as a screening tool, so all women, even without any symptoms, if they undergo, that is a screening mammography. So here the goal is to find out the two small lesions which are not felt even by a doctors or even by a self breast examination. So effectively it is good for the women who are 40 years, but in India we can start doing as early as 35 years of age, because the malignancy rates are much earlier, one decade earlier than the Western population. And as a diagnostic tool, whenever they have any complaints of palpable mass or nipple discharge or skin thickening or nipple retraction, or sometimes if they get any eczema on the skin, especially nipple areola complex, those time you can do. And whenever you're planning for surgery, you always do both the mammograms. See, advantage of this one is there may be an occult lesion somewhere in the opposite breast, especially when you are when the biopsy shows a lobular carcinoma in a single breast. So lobular carcinomas tend to have a bilateral presentation. So you need to have basal mammogram prior to the planning. So other advantage with this is, once we do a mammogram, even in the positive patients, we will be able to have a follow-up examination once we give neoadjuvant chemotherapy and plan for surgeries. And when the lesions are too small and the surgeon wants to have a surgery done, so that's a time we can use a wire localization. And whenever after the surgery, whenever you're looking for the residual lesion, that time after the surgery, surgeon will send for a specimen mammogram. Based on the specimen mammography calcification or the margins, we can advise the surgeon to re-explore the corresponding margin whichever is closer to the surgical dissection plane. And as a follow-up, especially when you are seeing Barrett's 3 category of lesions, and as a follow-up of treated patients and post-radiation, and to evaluate any recurrence of the lesion. And we also do when there is no when there is a primary disease, unknown primary is present in the body as a metastasis of brain or anywhere, and we don't know the primary, so that is an occult malignancy. Those cases we can also do a mammography to see if there is any primary the breast malignancy. So here, coming to the mammography anatomy, the predominantly what we see is a radiolucent tissue, that is a adipose tissues, and visible densities, usually they are the glandular tissue which contains the lobular elements, ducts and fibrous connective tissue. So here is a thin hyperdense skin tissue, and below is a subcutaneous fat, and all those linear branching pattern which is similar in thickness, originating from the retromembrana, they are all the vascular channels. So many of the time the vascular calcification, they are like a branching fine calcification. We always get confused for the fine pleomorphic microcalcification of a neoplasm. So in such cases, the vascular calcification should also be considered, because once you follow it, majority of the time, especially in old age after 50 years, so the microcalcification and the calcification of the vessels will also mimic. And the glandular tissues, whenever you see a glandular tissue, so glandular tissue will have the unsharp margins in all over, and they will have a faded margin compared to the as it attached to the adjacent the fat tissues. And there will be a linear non-branching tissues which are extending from posterior to anterior. These are the ligament of Cooper, and they also non-branching can extend up to the skin. So these fibrous separations or ligaments of Cooper you'll predominantly see in a fatty breast like this. And coming to the interpretation, to avoid the to maintain the uniformity, American Royal College has come up with the ACR guidelines. So as per the ACR, we do a BI-RADS reporting, that is a breast imaging reporting and data system. So as per the BI-RADS, we have to have a format. First, the format, we describe the breast composition, what type of breast, whether it's a dense breast or the fatty breast. Then we describe the findings. After describing the finding, we give an assessment and also we give a recommendation. So this is a standard format of the ACR guidelines. ACR. So as per the ACR guidelines, first thing you should see is the density of the breast, whether it is extreme dense, heterogeneous dense, or scattered glandular tissue, almost entirely. So here, generally in a young age, or in a lactating woman, or a nulliparous woman, all of them will have a dense breast where the majority of them are the glandular tissue. So that when the 90% tissue is the glandular, that becomes extremely dense. So here the problem with us is the sensitivity is very low. Next is heterogeneous dense. Generally we see it in the middle age group, in the Paris women, where the glandular tissue is almost 50 to 75% of the total, and there are scattered glandular tissue, so which is majority of the time we will see in a perimenopausal age, where it is very easy for us to report. We just have to see the densities where there are patchy bright areas are there, and almost entirely breast it is where the glandular tissue is nearly absent. And based on this, your sensitivity of picking up the lesions also will vary. Once there is a dense tissue, the sensitivity is as less as 60%. When there is a density is very less, in a fatty breast, the sensitivity of mammogram goes up to 70%. So this is a type D breast where you see nearly you're not seeing any flat glandular tissue within it. So this is an extremely dense tissue or diffusely dense tissue. So the problem in this, even if there is a lesions, will miss out. So majority of times when you're reporting, so make sure that whenever you put it as ACR type of density as a D, make sure that you put it as a BI-RADS category 0. So category 0 is always includes an additional information required by either you can do a mammography, or you can do an MRI, or you can do an additional spot compression. When it comes to a type C category, where the glandular tissue with the bright glandular tissue is seen, within that glandular tissue you can see oval opacities of the fat globules will be seen. But these fat globules, they are all very small, less than few millimeters, like few 3 to 5 millimeters. They are very small, and if you are seeing these kind of densities, you can put it as type C. Again, when the lucent component of the gland in between the gland tissue is bigger than the density of the glandular tissue, then it becomes type D. Okay, so usually you can't put the percentage as 50, 60 or 70%. So it is just a visual analog. Whenever you are seeing the fat tissue bigger than the glandular tissue, you will put it as a Barrett's HCR type B. So whenever the glandular tissues are much bigger than the fatty tissue between the glands, then it becomes the type C. So whenever there is very streaks of glandular tissues there, very thin rim of glandular tissues there, that becomes the type D. So here, along with this, you should know there are some changes happens with the age. So what is the stage? So the changes are the involution of the breast. So here, as you can see here, there are, I'll put a pen here. Okay. So as you can see here, the compared to this is the outer quadrant, this is the upper quadrant. So this is the area which has a maximum density. So whenever you are seeing reporting, you compare with the opposite side in the same symmetrical way. Here also you compare, and any density which is more than upper outer quadrant is an abnormality. Okay. So here you can see compared to the lateral quadrant, the medial quadrant, the fat tissue is less. So here as compared to upper quadrant, the inferior quadrant has a less tissue. So this is the normal glandular patterns. Okay. So as the age progresses, this part will disappear. This part of glandular tissue will disappear. Again, the lower quadrant glandular tissue will disappear as the age progresses. Coming to the glandular tissue per se, so here, whenever you see a gland, you see the margins. Whenever there is a fat, you see the fat margins, it will be concave. Whenever you see in junction, in conjugation with the gland tissue, they are all concave. Here also it's all concave. So only in the subcutaneous plane they are all straight. Okay. So whenever you feel there is a convexity present in the glandular tissue, that is the indication for the mass. So other indication is normally with the age the glandular tissue becomes a thin fibrous. Okay. So whenever you get a thin gland like this, these glands as it goes to the periphery, the margin should become faded. It should disappear smooth. There should not be any sharp termination. So here also you can see from here as it goes periphery, you can see that there is a faded margin. Again, in the glandular tissue, when you see the junction of fat and the gland, here this area it has a faded margin. You are not seeing a sharp demarcations. Okay, so this is how you see the normal architecture. But this is in a dense breast. When you come to the scattered tissue, again the scattered tissue, the glandular components are bigger than the gland tissue. Sorry, fat globules are bigger than the glandular tissue. So again, here also same principle. You just observe the glandular tissues which is having a faded margin, or you can see the fat tissue which is having a concave surface outwards. All the interface between the gland and fat, they always have a concave margins. But once you see a lesion, it becomes a convex. So the moment you see the convex, that means there is a density, there is an abnormality. Here also you can see, compare these areas, there is a convexity is here. So this is also a lesion. So this is an obvious lesion, but you should be able to pick up this lesion also. Okay, and there are some opacities here. This is also very important. This is called no man's zone. In the retromemory zone, where the fat tissue which is parallel to the gland, parallel to the pectoralis major, should always have a fat tissue. If at all no fat tissue, there should be a gland which is having a blurred margins. So whenever you don't see a continuity of the glandular tissue to this area, and if you see any lesion is suspicious. Yeah. So you see the convexity of the mass, and here you can see the compare the margin of this gland tissue. Here it is a faded margin, compare the margin of this gland tissue. So this is a sharp margin with the lucency. Here you get an unsharp margin. In fact, you can say it as a blurred margin. So this is the normal tissue. This becomes a type 2 glandular bireds to lesion. Again, this is another example where the glandular tissue is there are some glandular tissue which is present in the outer quadrant, but whereas this area is totally disappeared. So now when we see only one view, it appears this is a mass, but whereas in other view it is not seen. So in these areas you should always compare the density of outer quadrant to rest of the density. So if they're equal, not to worry. If the any density which is more than this area becomes abnormal. And here you can see that glandular tissue, all this the tissues which are thinned out parenchyma, you can see they are all triangle shaped. They are all triangle shaped like this. Here also they are all triangle shaped. So all these thin fibrous tissues, whenever with the age, they all become thin fibrous. So this you should not confuse for the ligaments of Cooper. See, you can see the ligament of Cooper, they are all linear lines and with that not branching. Whereas these lines, as you can see, they branch slowly. Along with that, they have a faded margin. So this is a normal thinned out parenchyma. Now, once we got to know the normal architecture in a type C and D breast and B breast, now we will jump on to the how to identify the lesion. So once we identify the lesion, we can describe whether there is a asymmetrical density or architecture distortion or a mass if we are able to find a lesion, or if there is no lesion, sometimes we can see only calcifications, or even if there is no calcification, sometimes we can see only associated structure changes. I'll give examples of each, I'll describe and give examples of each. So asymmetrical density is a one if anything which is higher than the upper outer quadrant becomes the asymmetrical density. So example, once you see some density which upper outer more than upper outer quadrant, you give a spot compression. Once we give a spot compression, you can see if you see a mass, you define whether it is well defined or ill defined. So if it is well defined, it becomes 2. If it is ill defined, that becomes a bireds 4. If there is no mass, that becomes a normal tissue. Again, based on the types of density, there are 4 different types of densities. One is asymmetrical density, focal asymmetry, developing asymmetry, and the global asymmetry. So now we'll give example of each. Now in this view, I am seeing the density only in the outer quadrant. Rest all glands are disappeared. But the compared to other areas, these densities are much higher, and I am not it is not looking like a mass. So this I'll compare with another view. So in this other view, I am not seeing like a density in the medial lateral view. So this is seen only in one view. So then it becomes only asymmetrical density because it is seen in the single view. Only in CC view it's seen, not in MLO. So this becomes a only asymmetric density. So what you do, you give a spot compression and see if the glandular tissue remains or persists. Again, in this view, we can see that compared to the left mammograms and the right mammogram, so both in CC and as well as in the MLO, you are seeing a density. So this becomes a, again, when you do a spot compression, I can see that still it is just the remnants of the glandular tissue. There is no mass. So this becomes a focal asymmetry, and this is a normal gland. So here in the this part focal asymmetry, I am seeing in two views. And again, this is I'm seeing in both the outer quadrant as well as central gland as well as in the outer quadrant. Again, in the MLOU, I can see both in upper as well as in the lower quadrant. So here I'm seeing the density in both two quadrants. So that becomes a global asymmetry. Since this tissue, this density is more than the upper outer quadrants, though this becomes a suspicious. Again, so that is a global asymmetry. There is something called a developing asymmetry. So developing asymmetry is a one which was not there in the prior mammograms and now it has present. That's called the developing asymmetry. So usually the developing asymmetries will be so tiny. It will not be seen in the prior mammograms, or if at all it is seen, it will be very small. You could have missed it. But in the later, if you pick up a small densities like this, that becomes the developing asymmetry. Again, once we see the lesion, we are able to describe the lesion in two views. We call it as a mass. So once we see the mass, we describe the size, shape, margin and density. So in the shape, we can put it as a round bowl, lobulated, irregular or architecture distortion. So this is an example. Here I'm seeing a thin lucency all around the lesion. So this becomes a, again here I can make out a thin lucency all around the area. So this becomes a well-defined mass with the smooth margins. Again, so here I can see all speculations are there, even anteriorly and the posteriorly. So in this view, actually I am not seeing this lesion, I am not seeing in the mammogram on the CC, whereas in only in MLO it is seen. So this is a speculated margin, but this is a smooth margin. So sometimes you not, because of overlapping, we may not be able to see it on one view, but even if you see it in a one view with irregular margin, you can put it as a speculated margin relief if the margins are speculated. So this is another example. Here I can definitely say that there is a density much more than the outer quadrant. Along with that, I can see some irregular margins are there. Along with that, you can see the fat line which is anterior to the pectoralis major, it's all loosened, but when it comes to the retromemorysm, you can see that there is a density. So this is definitely abnormal, but as such I am not seeing any posterior margin. So this margin I am not seeing in a MLM view. But when I do a CC view, I can see the speculation of anterior margin, I can see the posterior margin, and even the lateral margin also I am able to see. So this is an advantage of the proper compression. So if you don't give a proper compression, the speculations will not be seen obviously. Again, here one more important point to note is the always you get the anterior margin as speculated, but whereas the posterior margin is not speculated because posteriorly there is no tissue to distort. So that's why majority of the times even though there is malignancy, you can see that posterior margin is well defined, whereas the anterior margins are speculated. So this is another example where you see a large mass and with some lobulations. This is a lobulations in the anterior, and sometimes you are not able to see the margins in one side, whereas you are able to see the almost 75% of the margin you are able to see. We can call it as well circumscribed margins, and this becomes a lobulated lesion. Again, so when you are not able to see the densities higher, again within the densities you just observe the fat globules. See here it's all whole, here it's whole. As we come here, the fat globules are little linear. So look at the margin here. It is a very sharp margin. But look at the margin here. This is slightly speculated. So such cases, what you do, I'm not sure of the lesion here or here. So we did a spot compression. On a spot compression, I can see that these fats are linear. Compare these fats which are round, these fats are linear. So this is a typical architecture distortion. Remember, architectural distortion need not have a mass. So when you have a mass with architectural distortion, then you can measure the mass. If you don't see a mass, you can just put it as a architecture distortion. Again, so here I can see multiple densities are seen here, but I'm not seeing in margins clearly in some of these areas. But when I did a spot compression, I can see that these fats are linear and they're converging to a central point. Whereas look at the other glandular areas, they are all round and lucent with a blurred margin with the adjacent glandular tissue. So this is all benign ones. These are the infiltrative margins. So this is a malignant tissue which is having a architecture distortion. Along with that, we can also see a small lesion. So always, whenever you see a mass with a speculated margins, you always see an adjacent tissue. Make sure that if the equal density opacities are seen without obvious clear margin, you can always say put it as a satellite nodule and do an additional spot compression so that these margins can satellite nodules can also be picked up. And again, sometimes you will see architecture distortion, it's very subtle, but you can see a thick halo around the lesion. So this thick halo indicates the infiltrations. Now, along with this mass, we can also see the density of the lesion, whether it is isodense or higher dense compared to the upper outer quadrant. Sometimes if the lucencies or if the tissues contains a fat containing, it is very easy and we can downgrade or upgrade the disease based on the content. So here in a ML view, it all looks isodense. I am not seen any posterior margin irregularity, not even anterior, but I am seeing some lesions here, some density is slightly here, but I am not sure. But when I did MLU, I can see that there is a small sharp margins in the lateral area. So this is an isodense mass. Again, this is an CC and MLO. Here I can see a thin lucency, well-defined mass with a thin fat lucency we can make out medially, and also within that, within the well-formed mass, well-defined mass, I can see the glandular tissue, I can see the fat containing tissue. So this is a typical isodense mass with the fat lucency. You typically see it in a hematoma, that's also called fibroadenolipomas. Again, majority of times we get our lesions like this with forget about the outer margins which may be irregular. Look at the inner margin. The inner margins are sharp and well defined and contains a lucency. So there can be calcification, there might be calcification. This is typically seen in a oil cyst or a fat necrosis. You will get this lucent margins, lucent tissues. Again, another common lesions what we see is calcifications. So in the calcification there are benign and malignant. Typically benign lesions are coarse calcification, suspicious or branching or pleomorphic, and based on the size we can call it as macro and micro. And typical the macro calcifications, they are either vascular, popcorn or lucent with the centers, and malignancy they have different distributions, whether it is pleomorphic or monomorphic or amorphous. I'll give examples of each. So this is the calcification which has the central lucency. So this is lucent, this is a popcorn calcifications, and these are the rod-like calcification. All of them are the benign calcifications. Whenever it is suspicious, they will be more pleomorphic or they'll be branching. So this is an example here in the ML. You can see a subtle irregularity, a subtle architectural distortion here. But when I did spot compression, I can see a fine microcalcification in the, these are the fine microcalcification. Again, in this I can see a dense tissue, but I am not obvious with the type of calcifications. But when I did a spot compression, I can see that there are the fine branching calcification. Remember, the microcalcification, the size is not that significant. The pleomorphism is more significant. Here, if you take the size criteria, this is definitely more than 2 millimeters. So it cannot be a benign calcification. But when you consider there are round calcifications are there are linear calcifications are there are branching kind of calcifications are there are comma shapes. So there are, once you see more than one type of calcification, you can put it as pleomorphism, and in this case don't consider size as the criteria to call it as microcalcification. So you can put it as pleomorphic calcification. Once you use a pleomorphic calcification, that is more significant than just putting as a microcalcification. So here there is another small nodule I am able to see in this. So when I did a spot compression for this, so it turned to be a whole mass with a thin lucency, but to surprise I am not seeing any lesion here. But when I see it in spot compression, I can see a spiculated mass. So this is a small, and also you can see a small microcalcification in this. This is a small lesion with the architecture distortion. Sometimes you may not able to see a mass or calcification, but there can be a supplementary imaging can give you either the skin thickening or nipple retraction, sometimes actually lymph nodes. So this, in this case, I can see subtle skin thickening or nipple retraction. I'm not seeing an obvious mass, but when I did a spot compression, I can see that there is a architecture distortion with the mass in the retroareolar area. Again, in this case, there are some lucencies, double skin lucencies are seen. Whenever you see like this, this is the skin fold. So whenever you see the skin fold, either it has to be a post-operative case or it has to be a skin fold because of skin puckering. Here you can see the lesion infiltrating into the skin. Because of this, there is a puckering or the pulling of the skin due to infiltration. And to surprise, there is one more small nodule which is seen in the inner quadrant as well as in the retromemory zone. So this is suspicious. So whenever it is obvious, don't just look at the obvious lesion. You should also look at another lesions. This, instead of become a single, it becomes a multicentric disease, and these are candidates not for the breast conservative surgeries. So your role is to pick up not just a primary lesion, also search out for any satellite nodules, search out for the ductal extension and any other lesion anywhere else. And here, once you see the describe the lesion, you should be able to tell which location it is. So it's a common terms we use. In a CC view, whichever is a marked side becomes outer, whichever is unmarked become inner quadrant, and in MLO, whichever is closer to the pectoralis major become upper, away from it becomes a inner quadrant. When you are a breast radiologist, you can't just call it as a upper and inner quadrants. So along with that, you should be able to call it, we should try to put a clock position. So marker, this is in the right breast, the outer part becomes the 9 o'clock position and the inner part becomes a 3 o'clock position. Again, in this you divide the lesions, the outer quadrant into two halves, and that becomes either 10 o'clock or 8 o'clock or 7 o'clock or 11 o'clock. Again, the inner quadrant you divide, that becomes either 1 or 5 or 2 or 5. In MLO, you divide upper quadrant, it becomes 11 or 1 o'clock or 12 or 1 o'clock. So similarly in the lower quadrant. Now there is a lesion here. This I can say that this is around 1 o'clock. Okay. Now coming to Barrett's assessment, once you see the lesions, you put your findings into the lesion, and based on the findings, you put the either it is, if it is a no findings, you can put it as negative, they will go for normal lateral follow-up, and if it is benign findings, you put it as for interval follow-up. And if your findings are not clear cut, then you put it for BIRAD 6, BIRAD 3, where you opt for follow-up. Whenever you see extreme types D breast, you can always go for a 0 category, where you can go for additional projection mammography, and it also gives us to a sonography. And whenever suspecting, you always put them for a biopsy correlation. You put it as BIRAD 4 when there is obvious lesions are there, like speculated margins or pleomorphic calcification, then you can put it for a higher category, BIRAD 4. But whenever you get a proven case coming to you, you can put it as BIRAD 6. In this case, you put an additional findings. So these are some of the cases which I thought it will be interesting for the PGs to go through. So I'll give few seconds, 5 seconds to see this. This is a dense breast, both sides. This is a spot compression. Look at these calcifications. These calcifications, they are not bright calcification, they are soft calcifications, and all of them are round in shape. So we did the ultrasound scan for this. I can see a cystic areas, I can see a small bright calcifications along the, this is along the duct, this is along cyst wall. I did elastography also. I can see that there are calcifications even in ultrasound scan. In elastography you can pick up the calcifications. So this is a fibrocystic disease. This is another lesion. There is a density in the outer quadrant, but here I am not seeing. This is spot compression. Can you see a small calcification, tiny calcifications here? These are amorphous calcifications. Here I am seeing a lesion, either it could be axillary lymph node. Look at the cortex and hilum difference. Look at, there is a taking of the cortex of this. So definitely this is suspicious. Coming to the breast part, here the posterior margin I am not seeing. Here also posterior margin I am not seeing. Whereas the anterior margin is subtly blurred out. Here the margins are slightly ill-defined. The moment it is ill-defined and retromemory zone, you categorize into BIRAD 4. This is a biopsy proved it. This is IDC. Yeah. So this is an other lesion. Lymph node is positive. Here there is some opacity is there. Here there is opacity, but there is one more opacity which is medial to that, and this is a ductal extension of this. There is one more small lesion is there. That is a satellite nodule. Any guess? There is opacity here. There is opacity here. There is opacity here. Which is more suspicious? This one. So it is there in the retromemory zone. Whatever you see in the retromemory zone is always suspicious. So even though it look like a smooth margin, but some of the margins are sharp. So that is a retromemory zone. You take it as a no man's zone, and it was a biopsy proven malignancy. So this is post-operative case. You can see a skin staple there. You can see a straight line here. So whenever you see a straight line, either this or this, it is a post-operative status. Now, spot compression. I can see a pleomorphic calcifications here. So this is amorphous microcalcification on a dissected margin. So this is a case of recurrence. Yeah. So here a large lobulated mass is seen. Here also large lobulated mass. We did ultrasound scan. Along with that, I can see a vascular mass here. What could be this? This is well defined. The margins are well defined. Here also you can see well defined. There is no irregularity. There is no speculations. Only capturing point is the vascularity. So whenever the large mass comes, this is around 6.5 centimeters. Whenever a large mass comes with increased vascularity, you always suspect a filaments. So this is another lesion. I'm not seeing in MLO view. One second. So I'm not seeing any mass here, but when I did tomo, I can see that there is a speculated mass here. This is a speculated mass. The same speculated mass is seen in this. So this is a speculated mass seen on the tomo, same area, but here it is not at all seen. So whenever it is a dense breast, retrospectively I can see a small speculations here. So to conclude, mammography is a basic diagnostic tool and is very sensitive, and it has a direct implication on the treatment plan if you detect early. So it is very effective when you do with the complementary on ultrasound scan, especially in a dense breast. And ACR biopsies will help you to evaluate and categorize the breast lesion. And in indeterminate conditions, you always go for a biopsy. Don't go for FNAC. Okay. FNAC is only for the lymph nodes. When you're too tiny, when you're not able to get access, that time you go for lymph node FNAC. But for breast lesion, you go for biopsy. Thank you.
Thank you, sir, for enlightening us and giving us a fresh perspective on mammography. I'm sure the audience here today echo gratitude to you for sparing your time to share your immense knowledge with us. So, sir, we have a few questions in the chat box. The first is how to report fibroadenosis on mammography.
Fibroadenosis. So you just have to describe the lesion, whether it is well defined or ill defined. You need not categorize into a fibroadenosis or benign proliferative disease or fibroadenoma or fibrocystic. You need not mention in your report. What you need to mention as per the BIRAT's recommendation, you just have to describe well defined or ill defined. Fibroadenosis is a well defined and you are putting in a benign category. So put it as BIRATS 2. That is enough. You need not put it as fibroadenosis. So don't commit yourself with a microscopic diagnosis. Unless you are very clear, very obvious, like the cluster of cysts are there, well formed, and fibroadenoma well formed is there, that time you can commit. With a well encapsulated fibroadenoma, you can commit as fibroadenomas. But generally, I don't put fibroadenosis in my reports. If it is fibrocystic disease, cluster of small cysts and cysts are very well formed, contents are clear, then I'll put in a cluster of cyst and then I'll commit with a fibrocystic, but not fibroadenosis.
All right, sir. The next question is how does mastitis carcinomatosis appear on mammography?
Mastitis carcinomatosis.
Yes.
So mastitis, as the name says, it is a condition where you get a florid edema. So there will be a edema component from the skin, subcutaneous pain, around the lesion, you get a spiculated margins and florid edema. And most of them, they are the clinical diagnosis with the short history. So whenever you see, for example, infiltrative ductal carcinomas, they will also have the same feature. They will also have a irregular margins. They will have a perilesional edema, but they will not have the subcutaneous fat edema. They will not have a skin edema unless they are not infiltrated to skin. Whereas in inflammatory carcinomas, it is a florid subcutaneous and parenchymal edema will be there with spiculated margins.
Okay, so that's about it. Thank you so much, sir, for your time today.
Thank you.
Moving on to our next speaker. Our next speaker is the very renowned and eminent Dr. Mukta Mahajan. Dr. Mukta Mahajan, ma'am, is a dedicated consultant and interventional radiologist. She's currently a consultant in Apollo Proton Cancer Center, Chennai. Ma'am has completed her several subspecialty fellowship training in breast imaging and interventional radiology from the Ottawa Hospital, Canada, as well as the Medical University of Vienna. Ma'am has also worked in Jaslok Hospital and Research Center, Mumbai. Ma'am is the co-author of Quality Assurance Guidelines for Breast Imaging. She's the governing counseling member at Breast Imaging Society of India. She was the editor-in-chief in Breast Imaging Society of India newsletter committee. She's been a member of European Society of Breast Imaging, Young Club Executive Member of Indian Society of Vascular and Interventional Radiology, Karnataka State Chapter, and a life member at IRIA. It's truly a privilege to have you here, ma'am, today. We welcome you, ma'am. You can please start with your presentation.
Mukta ma'am, can you please unmute yourself?
Are you able to hear me?
Yes, ma'am.
Okay, sorry about that. Dr. Sudhakar, first of all, great presentation. It was nice listening to you again. Thank you for the kind introduction right now. I'm just going to quickly share my screen and move on to the presentation. Are you able to see my screen?
Yes, ma'am, it's visible.
Okay, I'm just sorry. Okay, so I'm going to talk about basics of breast MRI, the technique, indications, and some basic interpretations today, okay? There are a lot of slides, but I'm going to just quickly breeze through them so that you get a good overview in order to further, your knowledge in breast MR through subsequent sessions. Sorry about the spelling mistake there, it's BREAST, sorry. So MRI technique. We'll include some basic protocols, what your technologists must do, also how to maximize the quality of breast MRI. The objective again today is to understand what are the basic requirements to perform breast MRI study, to recognize the importance of good positioning and to minimize artifacts that may lead to errors in interpretation, and as well as to be aware of some of the advanced techniques in breast MRI. So before we start, this is usual, it's always a contrast enhanced study when you're assessing breast for breast tissue per se, and if it's not a implant protocol for integrity, breast MR is always done with contrast. So you must get serum creatinine and calculate the EGFR level for possible renal dysfunction before the study, before planning the study. Also have the mammogram available on packs to interpret the breast MRI study. You seldom interpret breast MR without a mammogram. This is most patients who undergo breast MR have either a diagnostic indication or have a high risk indication, and then even if they're younger than 40 years, they do have an accompanying mammogram. So make sure you take a look at it. The time of the menstrual cycle, MR, when possible, when it's done for for reasons that does not include recent diagnosis of breast cancer should be timed at an appropriate menstrual cycle period, which is from day 7 to day 14. That's when you get the optimal background parenchymal enhancement is at its minimal, which does not come in the way of interpretation of the abnormal enhancing tissue in the breast. So 7 to 14 days, day 1 being the first day of the woman's menses. It's very important to understand the indication of breast MRI. It's an advanced imaging technique, and it is only as good as the its sensitivity and specificity is only as good as its indication. So if you start doing breast MR for all patients, your specificity is going to be really poor. You're not going to have, you are going to constantly ask for additional imaging tests, and it's going to lead to unnecessary biopsies. So your indications of breast MR have to be crisp, or only then the value of MR is understood by the referring clinicians. It's important to find out if the patient has implants, so that you could add an implant protocol, additional implant protocol as well. So gadolinium, as I said, most breast MRs, and except for implant integrity, are with contrast. We know that the gadolinium is now known to accumulate within the dentate nuclei pons and global pallidus as well as thalamus. Especially patients who undergo more than 4 contrast MRI examinations. So this is also of some consideration and debate when these tests are used for screening or surveillance studies where patients have annual MRs. However, we know out of the 2 types, the microcyclic complexes are safer and have less association with nephrosclerosis as well as the accumulation in the brain. This is an example of how the same patient's MR looks when it's done in the second half of the cycle and the first half of the cycle. This is the first half when it's performed in the 7 to 14 days prior to her ovulation, and you see minimal background and the parenchymal enhancement. Whereas in the second half, it's a hormonally stimulated tissue which is showing so much of enhancement. So it's possible that in such cases, if there's a small papilloma or a small cancer or a linear non-mass enhancement, that may get missed because of the busy background parenchymal enhancement. So the 2018 revision of ACR practice parameters have included technical guidelines. The magnet strength of 1.5 Tesla is minimum. The dedicated breast MR should be performed in the dedicated breast coil. The slice thickness is 3 millimeters or less, and in plane pixel resolution of 1 mm or less. Chemical fat separation is recommended when you're doing high resolution imaging. It's recommended that you do simultaneous bilateral breast imaging, because breast is a single symmetrical organ, and hence it needs to be looked at simultaneously. The contrast bolus of 0.1 millimole per kg is given, followed by a saline flush of 10 ml. The scan time for dynamic images, kinetic images are required and interpreted where the 2 time points are 4 minutes or less. This adds to the specificity of your overall interpretation, and hence we need to acquire dynamic contrast images, which can give you kinetic information in terms of intensity plotted against the time. So this is how the dedicated breast coil looks like. The patient lies prone where the breast hang within the coil, and this is an area where patient's going to rest her head. So it's not a comfortable position for a lot of our patients. However, that's why it's very important to optimize the breast MR scanning time. It's also important to explain the patient that the non-contrast part of the study is most motion sensitive, and hence staying still during that time is most important. So it's something that you need to talk to the patient before she's positioned. The basic protocol, ACR does not include diffusion as a mandatory protocol. It can be done. There are several studies where Diffusion adds value and is being considered as, can diffusion eliminate the use of contrast in breast MR assessment. However, the standard of practice at present involves a water sensitive sequence, T2 weighted with fat or stir sequences, T1 weighted unenhanced sequences, 2 or more T1 weighted contrast enhanced sequences, with and without fat saturation, post processing with subtraction, and maximal intensity projection. So this is the basic protocol for breast MR. Now, depending on your institution specific protocol, you can add additional sequences such as a coronal T1, which is 1 mm thin, which is an excellent sequence to see to identify an intramammary lymph node within the breast, to see the fatty hilum, in order to not misdiagnose it as a small cancer. The axial T1 dynamic GRE contrast enhanced sequences, we do 1 mm. The sequences at 0, 1, 2, 3, and 7 time points. These are with FATSAT. And also the axial and sagittal high resolution FATSAT T1 isotropic voxel images with 1 mm thickness. So this is how the dynamic 3D acquisition happens. The pre-contrast, the post-contrast images are subtracted from the pre-contrast to give you subtracted set of images. It is very motion sensitive, as any change in patients, any movement during this time is going to alter your interpretation on subtracted images. Hence, it can eliminate an enhancement, or it can also create a pseudo enhancement sort of appearance. That's why it's important not just to look at the subtraction images, but to go back and look at your T1 post contrast fat suppressed image data set, the raw data set, in order to avoid misinterpretations because of movement. So we plot the time intensity curves, signal intensity against time, where you can see that the cancers show, rapid upslope, which can further have in the initial part of the study, which can further have persistent enhancement, plateau, or washout. These are the three kinetic slopes that we talk about. The washout kinetic is most suspicious for cancer, which has 97% positive predictive value. Plateau is next suspicious, and persistent is mostly seen in benign tumors. However, this is true only when we are talking about masses in the breast. It does not apply, the kinetics don't apply when we are talking about non-mass sort of enhancement. So some common findings we see in breast MR, these are T2 hyperintense cysts, some are showing fluid level, these are inflammatory cysts. It's typical for inflammatory cysts to show some post-contrast enhancement. This is again typically benign, and so then the fluid level can be because of the protein content or blood content within. And again, a typical benign lesion of fibroadenoma within the breast. It's a solid mass and shows non-enhancing septae within the mass, and it has a diagnostic value of more than 95%. However, not all non-enhancing septations are, confirm that it is fibroadenoma. For example, this mass over here, which is more than 2.5 centimeter, the patient tells you that it has grown rapidly. When you do a second look ultrasound, you must advise a biopsy, because it has multilobulated margins. So only presence of non-enhancing septations does not confirm the histopathological diagnosis of fibroadenoma. One needs to take the history in consideration, and also overall appearance in a morphological appearance on mammogram and ultrasound studies. This was biopsied and turned out to be a phylloides tumor. Again, a typical fibroadenoma 2-minute sequence shows the it's a T2 high signal intensity lesion to start with, enhancement progressive, as you can see. Again, benign morphology as well as kinetics. But when you're in doubt, you can do a second look ultrasound. Again, assess the ultrasound descriptors, use the ultrasound descriptors and look at the margins, the internal echo texture, whether it's homogeneous or not, whether it's posterior shadowing or enhancement. You can also assess whether it has calcifications. So based on your basic mammography and ultrasound skills, if there is any suspicious finding, this can be biopsied. However, this is how a typical fibroadenoma looks like on an MRI. Another common finding on MR, an intramammary lymph node, you can see an intermediate T2 signal intensity. You can also appreciate chemical shift artifact associated with MR because of the fat and fluid in the single voxel. You can, so these are well circumscribed, typical reniform fatty hilum is seen, and they can interestingly show gradual plateau or washout enhancement. So all three curves can be seen associated with the intramammary lymph node, and hence the morphology here becomes crucial for us to assess to decide the further plan. Now, this is also a lymph node. You can see that it's showing a washout kinetics on ultrasound. It's typically lymph node. It can't be anything else. Hence, it's BI-RADS 1 or even BI-RADS 2, or if it's normal size, you can even call it BI-RADS 1. Typically, it's adjacent to a blood vessel. This is a classic picture of fat necrosis where there's a T1 hyperintensity fat, which on fat suppressed images it shows signal loss. Another fat necrosis, which is post-surgical, it's a large area, very suspicious looking multiseptate like enhancement. However, this is nothing but fat necrosis and does not require any follow-up. This is an example of a locally advanced breast cancer with non-mass enhancement extending anteriorly towards this mass. There are also multiple foci. It reaches the prepectoral plane. However, there is no invasion of the pectoralis major muscle. It is close to the subcutaneous plane, but no invasion of the overlying skin. So it's basically telling us the extent of this invasive breast cancer, locally advanced breast cancer. This is a 3D MIP. That's how it looks like, where you get an idea of the entire extent in one single image. It also gives you a good overview in terms of what is the approximate volume of breast involved, whether breast conservation surgery is possible or not, and how is the pattern of the the background parenchymal enhancement. Are there any foci which are looking asymmetric? And that require further evaluation. So it also gives you in one look, and it gives you information about the axillary lymph nodes. It gives you information about if there's any abnormal skin or nipple areola enhancement. So this is a case where a young girl, 24-year-old, presented with a lump in the breast. She said she felt that she felt like it was more of a thickening, but it wasn't usual for her. On ultrasound, you can see a solid mass with multiple cysts in it. We don't really see margins. It has very indistinct margins. It's merging with the normal parenchyma adjacent to it. Some hyperechoic specks here. She was 24, hence we proceeded, but this was certainly suspicious. So we did her mammogram. No, we don't really see any discrete mass in her right breast, but the density is definitely more on the right side. It was also very hard for us to compress this breast compared to the contralateral side. So further, this was biopsied, and this was an invasive breast cancer. You can see on her PET CT, you can see the extent of disease. It's almost involving the entire right breast, upper half of the right breast. She also has enlarged axillary lymph nodes. Now, this is her T1 non-contrast, non-fat sat image. This is a T2, again, non-fat sat image. You can see a T2 hyperintense, multiple T2 hyperintense cystic lesions within her right breast. And there's an intermediate signal intensity. So cancers show intermediate T1 and T2 signal intensity as against the relatively low signal intensity of the normal breast tissue. Now, the next sequence here is the post-contrast images. This is the T1 non-subtracted data set, whereas this is fat suppressed images. Sorry, these are the subtracted images. And you can appreciate the enhancing mass involving the entire upper half of the breast. There are some non-enhancing necrotic or cystic areas within which were T1, T2 hyperintense in the pre-contrast study. There's also additional focus which is seen in the retroareolar region separate from the palpable mass. Another one which is in the lower outer quadrant, again suspicious for main mass. So both these targets were biopsied and shown to, and she had a multicentric breast cancer. Since this involved more than 25% of her breast, she had to undergo a mastectomy. Now, these are her curves. You can see a washout kinetic here, washout again. This is more of a plateau. So different areas, different slices adjacent to each other, 76 and 78 over here. They're showing different patterns of kinetics. However, the enhancing area, which is in the left breast, showed a typical persistent enhancement. So it has a very mild, slow upslope, and it has persistent enhancement in the delayed phase. So this is typical for a normal, a benign tissue. Now you may also consider additional sequences with the body coil, like a core oblique T1 or stir sequence, but this is obviously going to add additional time. And these are done to look at extramammary findings in bones, lungs, and nodal mets. So these are not standard, but this is based on individual indications as well as the institutional protocols. So now that we've discussed about the basic protocols, some tips and tricks for your technologists and to maximize the quality of breast MR, the positioning is the key. So our positioning goals are to image the maximum area of the breast tissue, to maximize the skin folds, to minimize the skin folds, to achieve homogeneous fat suppression, and to have a non-deformed breast parenchyma at the time of the imaging. So this is not as easily said as done. So we, in the positioning in the breast coil, we have to guide the patient into the coil, center the breast over the center bar, check the breast position from all positions, lateral, medial, superior, inferior. Repeat the positioning set for the check for the other breast as well. Now inside the coil, it's ideal to have the nipples in the equal positions. Nipples must be in profile. They should include all breast tissue, minimal compression on the breast, and also it's important to finally check that the top and the bottom of the breast is within the coil. Now, poor positioning in the coil, you can see here that there is a fold part of the breast, inferior breast is outside, which is seen here as well. And again, this is not going to, if there's any tumor here or non-mass enhancement, it's going to be distorted. There's also improper positioning where the inferior breast the patient is positioned way too superiorly. The breast is not central within the coil, and that leads to a signal flare, an artifact such as this. Again, the nipple is in poor position over here, it's folded over along the lateral margin. There's also wrinkling of the breast over here, and this can cause a pseudo lesion with skin thickening, whereas the corrected position over here, where nipple is seen in profile, you can now appreciate an abnormal, very subtle non-mass enhancement, which was earlier biopsied, which definitely is not appreciated in the earlier two sequences. So the signal flaring happens because there's non-uniform fat suppression when some breast tissue is very close to the coil elements, and it's also exacerbated by poor fat suppression. So this is again few more examples of the anterior part of the breast which is touching the coil, and the signal flare because of that. The signal flare can also happen when there is additional contact along the along the central part, in the medial part of the breast. So you can place a pad under the sternum in order to increase the height a little and give some extra room for the breast, and hence improve the overall fat suppression. So field of view is important. One must cover the anatomical region to maximize the spatial resolution, but it shouldn't be too large or too small. The FOV typically ranges from 280 to 320 mm. The oversized FOV will increase the pixel size, will include extraneous organs in the examination, and reduce the spatial resolution. Conversely, if the undersized FOV will reduce the signal and result in inadequate coverage of the breast tissue as well as the face wrap. So this is an example of an oversized FOV. This study is meant for breast. We are not interested in heart or what's happening to the aorta or the lungs in general. So this is a correct FOV for breast MR. Again, an undersized FOV where you can see the phase wrap artifact over here as well as here. So this needs to change as well. Motion artifact, this is our worst enemy in the breast MR because it can really it can obscure or create pseudo lesions, obscure true lesions or create pseudo lesions, and hence it must be avoided at all costs. This is how a subtracted image looks like when there's motion and misregistration. So here the motion artifact, which here it looks like a very vague non-mass enhancement. It does not raise any suspicion, and looks like a normal tissue. And there are also two areas here which actually are not true, but they're pseudo lesions which have appeared because of the motion. On a motion corrected subtracted image, you can see a clear demonstration of the linear non-mass enhancement, and this on MR guided biopsy was DCIS with invasion. So it's always important, as I said earlier, to check with the source images and not FATSAT T1 the FATSA breast images with the subtracted images to make sure that the motion artifact isn't precluding or creating enhancing areas which truly are not seen on the source images. So now we'll briefly run through the breast MR indications. We have seen, I think, techniques in brief. I think there is a lot more to it in terms of how to in terms of positioning, and there's some excellent articles which are available. But in terms of in the interest of time, we'll move on to the breast MR indications. Now, the commonest indications are they've divided into screening, extent evaluation, and additional problem-solving MRs. Starting with screening, it's indicated in high-risk patients, intermediate-risk patients, contralateral breast screening in newly diagnosed breast cancer patients, as well as patients with breast augmentation. Now, when it comes to high-risk patients, breast MR is known to significantly improve the detection of breast cancer, which can be otherwise clinically, mammographically, or even sonographically occult. So multiple European and American trials has proven that breast MR is most sensitive for diagnosis of breast cancer in a screening setting. Even in the surveillance setting, that is when women have greater or equal than 20% lifetime risk of breast cancer. Now, these could be women with genetic predisposition for breast cancer, such as the BRCA gene carriers, or they could be women who have had childhood lymphoma and have received mantle radiation. And who are at a higher, hence they are at a higher risk of breast cancer development as well. So anybody who has been identified as a 20%, who has greater or equal or greater than 20% lifetime risk of breast cancer, breast MR is indicated as surveillance. Now, high-risk patients are referred for breast MR annually, so they get an MR once every year, in addition to mammogram, at the same time or preferably 6 months interval. So mammogram for 6 months followed by MR, again 6 months later mammogram, and that's how their screening protocol goes. So this is, although we know that this is the high-risk screening protocol it detects cancer earlier than the routine screening protocol, which involves mammogram plus minus ultrasound. We still don't have direct evidence that MRI has reduced mortality by early disease detection in high-risk patients. The intermediate risk patients, which are considered as supplement to, MR is considered as a supplement to mammography screening with a moderately elevated risk. So high risk is when it's more than 20%. The intermediate risk is when it is about 15 to 20%. So they have also shown to be of value in the intermediate risk group. For one of the indications is when there's a personal history of breast cancer with dense tissue and breast cancer is diagnosed earlier than 50. These women can be surveilled with annual mammogram as well, annual breast MR as well. Now, the contralateral breast screening in a newly diagnosed breast cancer patient. Now, in this case, when you have a new diagnosis of the and there's an evaluation, extent evaluation MR or assessment of the contralateral breast, you don't wait for the appropriate menstrual period time. Even if the patient is in the second half of her period, I think the benefit of delaying her MR is far less than the risk involved of not coming to an early decision and prolonging the diagnosis of breast cancer, if at all, not just diagnosis but treatment of breast cancer. So hence we don't, in a newly diagnosed breast cancer, we don't pay much attention to the menstrual phase that the woman might be in. The breast MR is performed regardless. The bilateral breast MR, again in this setting, the literature tells us that the rate of detection of occult malignancy in the contralateral breast is at least 3 to 5% of the cases, whereas the contralateral breast cancer and the detection of this contralateral occult breast cancer reduces the incidence of metachronous contralateral cancer. So there's a clear value here, although it's in a small subset of patients. We'll talk more about the detection of occult breast cancer in the ipsilateral breast in after a few slides. So now in the patients with breast augmentation, breast MR is often used to assess integrity of the silicone implants. However, when patients have augmented breasts with silicone or saline implants or free injections of silicone, paraffin, or polyacrylate gel, mammography becomes really difficult for us to assess whether there's and its sensitivity and sensitivity mainly in terms of breast cancer screening becomes really poor. In this case, use of breast MR might be justified. So patients who have implants, dense implants which obscure mammographic screening can have screening MRs as well. Also, patients who have implant reconstruction following lumpectomy or mastectomy for breast cancer may also benefit from contrast enhanced breast MR screening. Now, a few examples of high-risk screening MRI where you can see a very small enhancing mass. You can see the left breast is already small. This is a BRCA patient. She's already had a breast conservation surgery on the left, and she's on surveillance. We are seeing a new enhancing mass in her right breast. Looks like there's a small cleft over here, maybe fatty cleft, fatty hilum. Question is this a lymph node? In a BRCA case or in any BRCA1 or 2, we know that the triple negative breast cancers have higher incidence, and triple negative breast cancers are notorious in terms of presenting as round or circumscribed masses. They don't present as these spiculated masses with architectural distortion or calcifications. They could be non-calcified plum round masses, and you may think that they are benign. However, it becomes important for us to remember that any new enhancing mass in a high-risk patient, BRCA1, BRCA2 mutant, should not be overlooked. You must always do a second look ultrasound to localize this lesion. It's also, if it's new, not seen on prior MRs, when the timing of the MR is correct, one must also proceed, if they have the facility, with MR guided biopsy. Now, in our case, we did not, in this case, a 6 months follow-up, there was no correlate on ultrasound, and 6 months follow-up was done, and this indeed increased in size. So fortunately, it was still node negative, and the extent of surgery did not change for this patient. However, this is how, on screening mammogram, the early findings can be really subtle and benign appearing. This was indeed invasive ductal cancer. Another example, again, benign looking small mass in the left breast. 6 months later, it has disappeared. So this was indeed a hormonally stimulated tissue. So it becomes important for us to pay attention to subtle findings when the indication is screening or surveillance, especially in a high-risk setting. Again, you can see left breast non-mass enhancement, which is in the upper outer quadrant, 2 minutes and 7 minutes. It is showing progressive enhancement. It was had low suspicion on MR. However, it is not seen in the contralateral breast. Hence, a follow-up MR was advised after 6 months. So this was BIRATS 3. This is the same patient who does not show now the linear non-mass enhancement is actually not looking conspicuous at all. And hence now we know that this was just hormonally stimulated normal glandular tissue, and now she returns to routine annual screening. So again, an example where the BIRATS 3 was now downstage to BIRATS 2. Or even 1, because this is a normal breast tissue and not an abnormality. Now, another case where there's a BRCA1 gene carrier, you can see a progressive enhancement and a very benign looking mass on ultrasound. However, this on biopsy turned out to be DCIS within papilloma. So again, a very important note that benign looking masses in high risk cases are not always benign. If they're new, if they or even if on baseline study, if we don't know whether they're new or not, it is important to do the biopsy to get the histological confirmation of the nature of the lesion. 31-year-old is showing non-mass enhancement branching in a segmental fashion. It is persistent. The early 2-minute and a 7-minute scan is showing that persistent, and also the time intensity curve, you can see that these are showing benign kinetics. However, this was DCIS. So the non-mass enhancement, we look at the morphology, whether it is suspicious morphology of non-mass enhancement or pattern of non-mass enhancement, and the importance is not given so much to the time intensity curves. So DCIS can show all 3 types of curves. So, but if it has clumped, branching, lean, segmental non-mass enhancement, it is suspicious and further evaluation must be done with biopsy. So now moving on to second set of indications for breast MR, the extent of disease. Now, in case of invasive carcinoma or ductal carcinoma in situ, to determine the extent of disease or the presence of multifocality and multicentricity in a patient with invasive carcinoma or DCIS. Now, as we again talked about it earlier, in the contralateral breast, the percentage of occult detection of occult breast cancer is about 4 to 5%, whereas in the ipsilateral breast, it's about 15%, and which can range from 12% to 27%. So, this is not a small number. So we do know that in almost up to 1/3 of the patients, 1/4 of the patients, breast MR can change the extent of the disease. Breast MRI determines the extent of disease more accurately than mammogram and physical indication. However, it still remains to be shown conclusively that this increase in accuracy decreases in the post-treatment recurrence rates and surgical re-excision. So this is an active area of research. Now, this is an example where a 40-year-old lady had come with a palpable concern in her upper outer quadrant. Mammogram, she has quite dense breasts, but we see clustered suspicious microcalcifications. She also had few 1 or 2 specks, inferiorly and medially going towards the nipple. However, it was not clear whether the morphology or the distribution of this additional few specks of calcifications was really suspicious. This is not looking good. Ultrasound correlate shows a fairly circumscribed mass, but it has very very heterogeneous internal ecotexture. Calcifications, the hyperechoic specs, you can see it's hard on elastogram. The biopsy also showed gave a guide on a 14 gauge gun, gave a diagnosis of low grade DCIS without invasion. Mass forming DCIS are more likely to be actually high grade and not low grade. So there is some sort of discordance right here. They're also known to be more multifocal. And since this patient had dense breasts, we decided to opt for preoperative MRI for extent evaluation. Now, this is her T1 weighted image, non-fat SAT. Again, let's go to left upper outer quadrant. So on T1, it is iso-intense. On T2, we are seeing foci of, this is the area of concern. There are foci of T2 hyperintensity. There is stir hyperintensity in the perifocal regions. Okay, now let's see the pre-contrast. T1 FATSAT pre-contrast images. This is early T1 FATSAT 2-minute sequences. These are 7-minute sequences, and this is a 7-minute subtracted sequence. So now let's come to the upper outer quadrant mass. So along with the enhancing mass, as you appreciate, especially over here, in the subtracted image, you're seeing associated anterior non-mass enhancement, which is clumped, and in the segmental distribution, and it's not looking good. There is linear, some branching as well. There are a few additional foci of enhancement, which are corresponding to a few specks which were seen on mammogram, but there was no correlate on ultrasound. So this lady certainly requires, if she's considering a breast conservation surgery, she certainly requires an assessment of how much of the anterior tissue that needs to be taken out. However, here nipple areolar complex looks normal. So these are color-coded maps. We can see the additional extent of the non-mass enhancement, how it is extending towards the nipple, and it's probably the intraductal extension. This is again from non-contrast to subsequent contrast sequences. You can appreciate that the non-mass enhancement is indeed showing persistent progressive type of enhancement. Now this is a second case. So first one, this again it tells us about, it changes the preoperative extent of the malignant disease. Now second case, there's a palpable concern in the lower inner quadrant, also extending towards the retroareolar region in the right breast. There is architectural distortion. MAG view, a cone compression view, is also showing a few specks of calcifications within another group here. But we don't see a discrete mass. Now on ultrasound, there's about 2 to 3 centimeter mass, but the area of palpable concern was much larger. The node is obviously looking abnormal and is clearly metastatic. PET-CT also shows an avid node. However, the area of increased uptake within the breast was again small, somewhere matching the ultrasound. Palpable concern on clinical examination and the area of involvement on mammogram were much larger. So there is again discordance in terms of size on different modalities. So now let's look at the mammogram. The T1 weighted images on the left without FATSAT, stir images on the right, T2 weighted images. So now in here you can appreciate the T2 intermediate signal intensity of the breast of the tumor in comparison to the T2 low signal intensity of the normal breast parenchyma. There's perifocal T2 hyperintensity, T1 hyperintensities are also seen. Sorry, this is a T2 non-fat and this is stir. Let's see the stir images. You can see the perifocal edema much better on the stir sequences. That's also extending into the prepectoral planes. And the enlarged lymph nodes very clearly abnormal compared to the contralateral side. So these were your anatomical sequences. Now on post-contrast images, you're seeing extensive non-mass enhancement and enhancing irregular mass. It is involving most of the central portion of the breast, medial portion of the breast, as well as the entire lower half of the breast. So there is, so look, we again going from below to above, lower half, medial as well as lateral breast is involved, retroareolar region involved, both medial and lateral. and upper central area involved, which shows a irregular mass. Again, this is the 7-minute subtracted sequence, which is showing progressive enhancement. In the contralateral breast, if you notice, there's a small enhancing focus right over here behind the nipple. Yeah, over there. So this is looking a bit suspicious as well. Now, this lady underwent, we could, again, the primary breast and the lymph node were biopsied. Both were suggestive of invasive breast cancer and metastases. The left breast, there was no correlate on ultrasound for the non-mass enhancement that was seen just behind the nipple. And hence she had to undergo, she was referred out for a MR guided biopsy. These are her MIP images. So MIP really gives you in one glance the true extent of the involvement. So as you can see, that almost part of the upper breast, the retroareolar breast, and the entire lower breast is involved by the tumor. So this involvement is definitely more than 20%, and there won't be good cosmetic outcome if a breast conservation surgery is offered for her on this side. So as against what we saw on ultrasound, which was only a 2 centimeter lesion, and on PET CT, again, a small lesion, the true extent really is seen on mammogram and best seen on MRI. The contralateral side, you can see this enhancing focus, but there's also a segmental non-mass enhancement, which is clumped and not looking like the background parenchymal enhancement. Again, no correlate on second look ultrasound. The enhancement pattern, as I said, that it's slow, uprise, persistent, not concerning. However, it's important to note that the most common initial phase, although it's fast uptake, it's only seen up to about 68% of the patients, and the delayed phase can have about 20 to 50% of the times you can see plateau, washout, persistent. So the commonest, again, is somewhere in the first two phases. However, persistent enhancement is also known. Again, the extent of the disease, how it's appreciated on mammo versus MR. So the true extent is what we see on MR, definitely not on ultrasound and PET CT, which is underestimating the extent. So most studies have shown that MR provides an accurate assessment, or it could be an overestimation of the disease, but it does not underestimate the breast cancer, the DCIS. That means that it has good sensitivity and a relatively good specificity for a tumor extent. It is, however, to compensate for the lower specificity. It's important that the additional suspicious lesions on MR, they should be biopsied. So before, for example, offering a contralateral, assuming that the contralateral non-mass enhancement is malignant, and offering either a surgical treatment for her left breast, it is important for us to prove it with biopsy, because even few high risk or benign lesions can show non-mass enhancement, and hence before changing the treatment plan, any suspicious lesion on MR must be biopsy proven, confirmed malignant on histopathology. This was biopsy with MR guidance, and this was high-grade DCIS with microinvasion. So as we saw earlier, DCIS can be hard to see on morphological images, sequences such as the pre-contrast images. It can be bright on T2 because of the ductal secretions or necrosis. The NME patterns, the non-mass enhancement patterns, the commonest is clumped, heterogeneous, clustered ring. Now, the second indication for the extent of disease is invasion to the deep fascia. It becomes very easy on MR to assess whether there is abutment of the pectoralis fascia or abutment of the pectoralis muscle, whether there's full thickness or partial thickness abutment. What about the serratus anterior, as well as involvement of the intercostal muscles? Now, in this case, it's very clear that there is invasion of the partial thickness pectoralis muscle. The additional features of locally advanced breast cancer, such as enhancing multiple foci, non-mass enhancement, and also abnormal enhancement of the cutaneous plane and nipple areolar complex becomes very easy to assess on MR. Now, the post-lumpectomy margins, I'm going to rush through this. So post-lumpectomy margins, it's very important for breast cancer to, it's very important for the breast surgeon to assess whether the positive margins are because of the microscopic disease, residual disease, or whether there is extensive multicentric or multifocal disease within the breast before deciding whether he's going to do a second surgery with revision of margins, or whether the second surgery is going to involve removal of the entire breast, which is mastectomy. So breast MR is planned before the subsequent surgical planning to identify occult multicentric and multifocal malignancy. The revision of the margins is a given because it's based on the histopathological report which says positive margin. But it's important to decide what type of surgery using the best MR findings. So this is one of the patients where the posterior margin was focally positive. However, the surgeon was clear that he had gone up to the anterior pectoralis fascia, but because of the presence of invasive cancer, this margin was decided to be revised. These are again morphological sequences: T2 with fat, T2 without fat. Pre-contrast T1, the initial sequences of early phases, and in the 7-minute post-contrast enhancement, you can see minimal enhancement of the post-surgical cavity. However, this could just be the post-surgical change and it need not represent tumor. So the only important thing that we understand from here is that there is no extensive multifocal or multicentric disease within the operated breast, and it should be sufficient for the surgeon only to revise the cavity, the operative cavity, to get additional margins. However, this patient also showed a small enhancing mass in her right breast, which was not seen earlier. There was nothing abnormal on her mammogram and ultrasound, which was part of her pre-operative assessment. And this mass was a complex solid cystic mass, and on VAB biopsy of this lesion, this was intrarectal papilloma with ADH and was also simultaneously removed at the time of the surgery for the left breast. Our post-surgical excision, however, showed presence of DCIS. There is a very fine line between ADH and DCIS, and that's why whenever ADH is diagnosed on biopsy, whether it's core or vacuum, there's always a recommendation of doing an excision of the abnormal area, because it could be underrepresenting DCIS. Now, this is again, this slide is talking about the same thing, that the post-operative MR can be accurately depicted if the residual disease is more than 5 mm, which is seen in this case, where you can see a nodular enhancing margin. There's also a non-mass enhancement, which is ipsilateral margin is quite, the inferior margin is quite thick. So this is a sign of residual disease. Again, when you see tiny patchy foci like this, there could be a lot of interreader variability. When the lesion is about 3 mm in thickness, one reader thought that this is residual disease, the second reader thought that this is just post-contrast enhancement. However, the excision showed that there was only 4 mm residual DCIS in the cavity, and hence the final margin was negative. So another important indication, neoadjuvant chemotherapy. Breast cancers which are locally advanced or have very aggressive biological subtypes, such as HER2 positive or triple negative breast cancers, are offered neoadjuvant systemic therapy in order to address the breast cancer disease systemically first prior to the surgery, and also in the effort of shrinking the size of the tumor to offer a better cosmetic surgery for the patient, and also downstage the axilla in terms of if there's an early axillary node involvement, and if post neoadjuvant therapy, if the axilla becomes negative, perhaps instead of axillary clearance, a sentinel lymph node biopsy can be offered to the patient. So there are various indications for neoadjuvant chemotherapy. have included in my talk today, but I don't think it's going to be possible for us to go through all those details. But the crux of the matter is that even as early as 6 weeks post chemotherapy, we can appreciate changes in kinetics of enhancement, such as there will be a slower wash-in rate, an absence of washout, and this changes, the kinetics changes they precede the change in the tumor morphology, so they precede the actual change in size and shape. Now, it's very important when you're assessing pre and post response assessment for neoadjuvant systemic therapy that we acquire a pre-neoadjuvant, pre-NACT MR in order to compare it with the post NACT findings. So again, you can see in a locally advanced breast cancer, pre-chemo, post-chemo, you see only few foci of enhancement, in residual enhancement in the right breast. Again, the kinetics have completely changed. Early there was a sharp uprise and a plateau, whereas here is like a persistent phase. So the MR, again, the response assessment is for residual disease. It correlates much better than the conventional imaging and clinical assessment. However, it's not perfect. Even when we feel that there's a complete tumor response after NACT on MR, there might still be tumor remnants in 30% of the patients. We'll skip through the indications. Just want to show you the types of response that the tumor can have post neoadjuvant chemotherapy. It can have a concentric shrinkage, or it can have a cookie crumble kind of appearance where it breaks down into smaller masses, but the overall size does not change. It can almost completely respond to the tumor. There might be no DCIS or invasive disease after NACT, or there might be only residual few DCIS at the site of the tumor. They can also be concentric shrinkage in addition to DCIS along the periphery of the tumor. Again, the total area to be excised won't change here. There may not be any change, so the tumor may remain completely unchanged post neoadjuvant chemotherapy. And those subtypes which don't respond to chemotherapy will also show interval increase in size. So we are assessing A, B, C, D, E, F, all these patterns of changes on a post neoadjuvant chemotherapy MRI. Again, I'm going to go through a few examples. For example, now this is an invasive ductal carcinoma, ER/PR positive, hormone positive, HER2 negative cancer, which has completely resolved on post-adjuvant chemotherapy. The node, which was enlarged, has now regressed and is showing near normal appearance. Another example, same. IHC, ER/PR positive, HER2 negative. The tumor has shrunk in size, but there is still residual disease. Again, here, this was a large area of mass and non-mass enhancement with skin thickening and enhancement. Similar IHC profile, and we don't see much change. So this is almost like stable disease on MR. As I mentioned earlier, the kinetics show the earliest change. This is a invasive cancer which is completely resolved. This is a benign mass, a fibroadenoma, which remains unchanged on the pre and post MRs. Again, so let's move to okay. So another example and another important indication for breast cancer is recurrence, to assess recurrence of breast cancer. Metastatic cancer when primary is not known and suspected to be of benign origin. For lesion characterizations, which is also called problem-solving MR, for post-operative tissue reconstruction, and for MR-guided biopsy. So we'll just quickly talk about a lesion characterization, problem-solving MR, and an occult metastases setting. This is a shrinking breast on the right. The patient had no other complaints. Ultrasound, mammogram did not show any. There was just increased density, but no architectural distortion or suspicious microcalcifications were seen. Right breast showed shadowing everywhere, but there was no discrete mass. But on MR, you're seeing almost the entire breast is showing abnormal enhancement, mass and non-mass enhancement, and this was a typical presentation for an invasive lobular breast cancer. So this is a problem-solving MR. So MR is going to also help you target the area for biopsy, and it's also going to assess the true extent of the lesion.